Good morning everybody and welcome to today's presentation. My name is Victoria Braid. I'm the online clinical education leader for Northern Europe and I am going to deliver today's presentation on injection parameters. I have in the question and answer box put my email address. If you have any questions throughout the presentation, if you could wait to ask them towards the end, because you may find that, that they actually get answered as the slides progress. And also, best to email me any questions so that I can reply to you, just in case what you ask me I need to do a little bit of research on and get you the most factual, accurate information. Also, for everybody that's registered and attending the presentation this morning, I will send you an attendance certificate and any useful information along with that may be of use to you or of interest. So today's presentation is the acquisition of Angio and CT parameters. So the point of this course is to understand the effect of image, contrast and contrast media on the quality of the image and dose. So at the end of the presentation you should be able to appreciate the scanning parameters that affect contrast, appreciate the parameters that contribute to contrast image quality, and also appreciate contrast protocols and parameters. And looking at different ways of how we administer contrast to the examination, be it via Mirror or Smart Prep. This is aimed primarily at radiographers and it should take probably about 30 minutes or so to complete. So these are the different sections of the presentation. We're going to look at acquisition parameters and then contrast management. We're going to look at the Smart Prep technique and the timing bolus mirror technique. So our exam parameters, we have our exposure parameters, which are kV and MA. We have the speed, which covers the pitch of the table, the amount we cover of anatomy and the tube rotation. And then reconstruction, we have the thickness of the slice that we either acquire or display, the kernel, which is the algorithm, so whether we're using a soft or standard algorithm, and whether or not we are using iterative recon, so that's in GE terms is our ACE, or our adaptive statistical iterative recon, which is our ability to reduce dose whilst maintaining image quality. Okay. So we'll look at RKV and MA. So if we're doing angios, vessels in Angio CT are high contrast structures. Okay. When our goal is to exclusively look at vascular structures, we can be flexible in the amount of noise that we're looking at. Okay. So if we're doing an examination where we're solely looking at vascular structures, we can have a lower dose, which is obviously going to increase the noise, but we're not interested in the differentiation of the soft tissue structures because we're looking at a structure that's going to have contrast added to it via the contrast media, so we're going to be able to see that. Okay, so in these instances we want to use a low kV. So if we want to save dose, if we have a standard 120 kV body protocol, it means that we can increase our noise by 10 to 20%. Okay, and the way that we do that is we use our dose steps in our MA control box, and every time we increase the noise, so that's a downward click, because if we downward click, what we're doing is increasing the noise by decreasing the dose. It gives us a 5% saving. So 2 clicks is going to give us approximately a 10% saving of dose. If we lower the kV, that improves the contrast in the image also. So if we're wanting to keep our dose down, we can lower the kV to increase the image. But by doing so, the lower the X-ray energy, the higher the noise, because the more of that X-ray beam is attenuated. So if we look at the speed, which is the pitch, coverage and rotation of the scan, so we need to adapt the speed of the scan in accordance to the physiology of the area that we're scanning. So if we're scanning carotids, we need to have a far faster acquisition time than if we were imaging the aorta, because obviously the blood flow is the arterial supply to the carotid is far quicker than if we're looking just at the aorta. We need to make our choices by scan time. Okay, so in neuro, we need to have a really quick scan time, and we need a far longer scan time for a peripheral runoff, because obviously the contrast is going to take longer to get to the distal area of the limbs. Okay. We do have a pitch booster, okay, and what this does is it helps reduce beam hardening. So we can see that without the pitch booster, we've got quite a bit of beam hardening from the ribs, whereas with the pitch booster, that's actually decreased. So we do have other technologies that, if we're going to increase the speed of the scan, which can cause beam hardening artifacts, we have technology that can help reduce those incurring artifacts. So then, if we look at the reconstruction of the slice thickness, the kernel and iterative recon, okay, so here, if we use a 1.25mm slice, we actually get a better signal to noise ratio than if we use a very thin slice. Okay, we use these very thin slices for our smaller vessels, okay, because we need to get the spatial resolution, because obviously the structure that we're looking at is far smaller. We don't always have to use a standard or detailed algorithm if we have got ASA on the system, because obviously if we're using soft, then this means that we are going to smooth out the noise within the image. If we're using ASA, because that technology tends to smooth out the image because we're reducing scatter, then you're going to want an algorithm that's slightly sharper. So here we have some questions. So how can we increase the contrast in an image if we're not using contrast media? So we've got either increase the table speed, decrease the kV, increase the slice thickness, decrease the tube rotation. and in fact it is all of those. So what we're going to look at now are the contrast management. So we're going to look at our injection parameters, the strength of the contrast that we use, and whether or not we use a saline chaser. So our main objective is to reach the optimal enhancement level. So what we have to bear in mind though is that if we're doing an angio, the time is limited because what we're wanting to image is the arterial phase. So if we've got a patient with good cardiac output and is reasonably well, the transition time is going to be quite quick. Okay. So for this we have to reach an adequate iodine delivery rate, and this depends on the iodine strength, the kV and the vessel that we're studying, and obviously the patient's health and their general demographics. Alright. As a general rule, we follow the principle that 3 to 4 mils a second is the slowest flow that we can go. Certainly now, because the acquisition of CT scans is so much faster, we tend to inject the bolus a lot faster so that we can keep the bolus of contrast a lot tighter, so that it then doesn't become too dilute, because obviously the physiology of the patients hasn't changed in the sense that it's still around 10 seconds for an arterial acquisition and around 65 seconds for portal venous. But obviously because we can now acquire whole body scans in a matter of 3-4 seconds, then this means that we can inject far faster to keep the bolus of contrast nice and tight. Okay. So a higher volume leads to a higher peak of contrast, but you need a longer duration for that to go in. Okay, and a higher flow leads to a much higher peak of contrast, but over a shorter duration. So we can see here an example of this. So if we look at contrast strength, a higher strength, so higher osmolarity, leads to a higher IDR if all the other parameters are the same. Thin and distal vessels are more difficult to enhance and benefit from a higher strength. So this is one of the reasons why we tend to use higher osmolarity in cardiac scanning and neuro scanning. So our saline chaser. If we follow our contrast injection by a saline chaser, we can actually decrease the volume of contrast that we're using, which is obviously far more beneficial for patients who have got renal impairment. What this also does is it helps to reduce artefacts in the superior vena cava and the right ventricle, because it's obviously mixing the saline in, and it means that when we come to image those structures, the contrast isn't quite as dense and therefore reduces any beam hardening artifact that may ensue. So we have a dual injection, which is one bolus at a higher rate to rapidly reach the optimal enhancement, but then that's followed by a second bolus of contrast, but at a lower rate, and what that does is then maintain the enhancement. So this is a useful technique to use in the run-up, where obviously we want to image right down to the feet, and because of the distance that we need to cover and the volume of contrast that's required, it can dissipate, which means that we get very low contrast images towards the distal end of the limb. So here we have our next question. What is the purpose of the saline chase? And it is in fact all of the above. So now we're going to have a look at smart prep and mirroring. So in dedicated arterial examinations, we need to know that when we're going to trigger the scan, it's going to be when the contrast is at its optimum. So if we use the technique that we refer to as smart prep, it allows us to real-time monitor the IV contrast in the area of anatomy that we're specifically interested in. And when we see the contrast reach peak enhancement, we can then trigger the scan, because we know the scan is going to take place when the contrast is we can see it is at its optimum. So the way that we do that is we go into our smart prep and we look at, we've got our parameters here. We've got our monitor location, which is the area we're going to monitor the contrast coming into, our MA. We have a monitoring delay, okay, and what this does is we know generally arterially it's going to take 10 seconds to get to the aorta. So it's pointless having lots of images with no contrast in, or very low density contrast, because we're just irradiating the patient unnecessarily. We have the monitoring interscan delay, so that's how much of a delay there is between each scan. So if we know that we're imaging something that takes a while to perfuse with the contrast, we're not going to have it every second. But then if we were imaging something like the carotid arteries, which we know fill very quickly, we're going to want this interscan delay as short as possible. Our enhancement threshold, so this is sets a threshold on a graph, so we know, we can see when our contrast is reaching what our enhancement threshold is, and that's generally in an arterial situation. We're looking at about 120 Hounsfield units, okay? And then our diagnostic delay is when we see our contrast where we want it, when we tell the system to start scanning, that's telling us how many seconds it's going to take for the scan to move back to the start position and start acquiring. So we need to make sure that this is as short as possible. So if we were interested in scanning our carotids, we're probably going to go from the arch of the aorta, because we're going to want to see the origins of the carotids. Now if we were imaging a circle of Willis, because we don't want a huge distance for the table to travel, we're going to want to image over the carotids. So if we see contrast in the carotids and we hit go, it's then got a shorter distance to travel up to the circle of Willis than if we say triggered from the same place as the carotids. So if we're doing a pulmonary angio, we want to set the slice at the carina, okay, and this also works the same for cardiac scanning. Now if we were imaging the full aorta, we're going to go probably in the mid aorta. So this is just a message that you will get when you're doing smart prep. You have 40 monitoring scans. If you exceed 40 monitoring scans, it pauses. It's assuming that you wouldn't need 40 seconds of of monitoring before you're going to trigger the scan. So that's important if you know your patient's got poor cardiac output, that you put your delay in, so you've got a short delay prior to any of the monitoring scans starting. So Smart Prep we want to use as a low dose scan because all we're doing is monitoring the arrival of contrast. Which of these parameters can be altered? And the answer is just MA. The KV that is used is the KV that you've done your your initial baseline scan with. So whatever parameters you use for your baseline scan, aside from MA, are going to remain the same. So we can't alter the algorithm, we can't alter the matrix, we can't alter the KV. All we can do is alter the MA. Now, something that you need to bear in mind is if you've got a patient that's quite large, as much as we want a low dose scan, you're advised to increase the MA because sometimes it can be that noisy, you're unsure that what you're seeing is genuine contrast into the vessel or whether it's actual noise within the image. So MIROI, and this stands for Multiple Image Region of Interest, and it's in principle a similar process to your Smart Prep. It gives you the optimum peak enhancement of when we're going to acquire the scan, but there's a slightly different workflow to it. Okay, so MIROI is used when we need to know exactly that the contrast is going to be where we want it at exactly the right time. So if we think back to our Smart Prep, we had a diagnostic delay. So when we hit start scan, it can take a couple of seconds for the system to get the table to the correct position before we start acquiring the actual main acquisition. And in that couple of seconds, the contrast can have gone from very isodense to quite loosened, okay, because obviously the contrast is moving through the blood. If we need to know that at 7 seconds the contrast is going to be at its optimum peak enhancement, this is the technique that we're going to use. So MIROI takes lots of images from a single series, okay, with a small test bolus of contrast. So what we would do is exactly the same principle of using Smart Prep. We would do a single slice over the area of anatomy that we're wanting to see enhanced. But the difference is that we would run a small test bolus of around 20 ml of contrast, and we would get the table to remain stationary, and we would do lots of images in that same area. Okay. We would then, in the same way that we would with our Smart Prep, we put a region of interest, but the difference is we're doing this retrospectively rather than prospectively. So in Smart Prep, we'd put the region of interest on and watch the contrast enhance within that region. We've already got some slices with iodine in, and we're finding out at what point this actually peaked with contrast enhancement. Okay. So when we put our region of interest on, we ask the system to generate a graph, and it gives us a contrast peak. So this is as the contrast is coming in and then washing out. So we can see after 7 rotations or 7 acquisitions, we've reached our peak. Each one of these rotations is actually 2 seconds. So it takes 14 seconds for our contrast to peak. And we know that we put a little bit of a delay on prior to the contrast arriving, because we don't want a whole heap of non-contrast images. So you would look at your peak, which in this instance is 14 seconds, and we had 5 seconds delay before any scans actually started being acquired. So the benefits are actually that it's completely time specific to each patient. So we find our enhancement delay, and then we go back to our, I can just bring this slide back up. I've not got the image, but we have on the next one here time of delay. So we would find our delay. So in the argument of this patient, it was 19 seconds, and we would type 19 seconds in here. So if we were scanning, in this instance, a CT pulmonary angio, we would trigger our contrast and our scan off the same time, and at 19 seconds the acquisition would start. So it works in the same way as when we have a timing delay for our portal images. The other bonus is that we can also alter multiple parameters. We're not restricted like the mirror. We can alter KV and we can alter MA, okay, unlike Smart Prep. So to summarise, we've looked at the effect of scanning parameters, so KV, MA, table speed, that affect the contrast within an image. We can appreciate the parameters that affect contrast and image quality, and we can look at the different ways that we can use acquisition techniques, so mirroring, Smart Step. So that is the end of the presentation. You can see here we have a side for gecares.com. You have the opportunity, if you want to review this presentation, to listen to it again on GE Cares. Also, if there are any presentations that you haven't been able to connect to, you can also listen retrospectively to those presentations as well. When I send you your attendance certificate, if you would like me to sign you up to GE Cares, if you're not already, a member of, then please send me your details, and I will send you a link that will give you all the information that you need to access this. Okay, thank you very much for your time, and if you have any questions and answers, please don't hesitate in emailing me, and I'll be only too happy to answer any questions that you have. Thank you.